Welcome again to part 3 of the congenital heart disease acyanotic heart. We're going to talk about the ventricular septal defects. Ventricular septal defects are 30% of all cases of congenital heart disease. Their presentation is usually early with a loud murmur noted on routine examination. A VSD presents in the first months of life. Most will close spontaneously during the first few years of life, with less than 10% requiring surgical closure. This is the classification of the ventricular septal defects. Ventricular septal defects are classified according to the size, the site, and the number of VSDs. According to the size, they might be small, moderate, or a large defect. The site, they might be muscular or perimembranous. The number might be single or multiple. And that is why you cannot answer straightforward when the mother tells you, my baby has got a VSD. What will happen to my baby? What will happen to my child? You have to understand that all these factors affect the clinical picture, because a small VSD might close spontaneously and is frequently not associated by pulmonary hypertension. But then again, a moderate defect might or might not decrease in size early in life, and a large defect, though most commonly does not close, but sometimes it does. So it is very difficult to give a straight answer and tell the mother 100% when will it close, because it is also affected by the site. So you tell the mother, okay, you have a moderate defect, we have to follow it up. Some defects might close, but larger defects will not. Muscular defects present in the muscular part of the interventricular septum commonly close. But if they are multiple and they are large defects, they might or might not close. Perimembranous defect. If larger perimembranous defect like those, for instance, in tetralogy of Fallot, they do not close. Of course, this is a complex heart. What is the clinical picture of ventricular septal defect? What are the symptoms? As we mentioned before in the ASD, sometimes the patient is asymptomatic and he is discovered by auscultation of the heart. The patient might present with recurrent chest infection, and this is the first presentation. The patient comes to you with a chest infection and you discover that there's a murmur on the heart. Heart failure with breathlessness and failure to thrive. And again, failure to thrive might be the first presenting feature. So the mother might come and say, الولد ده ما بيكبرش، أنا ما بيرضعش كويس، أو ممكن تقول بيرضع والله بياخد الرضعات بتاعته بس برضه ما بيكبرش، ده طول النهار عرقان ونفسه كده هو سريع. وقتها أكون عارفة إن this is symptom of heart failure. Cyanosis might occur due to pulmonary vascular disease, and I'm going to explain what is pulmonary vascular disease. And infective endocarditis might occur because there is a difference in pressure between the left ventricle and the right ventricle, and the rush of blood and the jet of blood can cause injury and infective endocarditis when it passes from the left ventricle to the right ventricle. In general, on examination, this child shows growth failure. وأي طفل عنده congenital heart, we have to take the weight and the height, and we follow by the weight and the height and the centiles. It is essential. It is part of the examination that we take the weight and the height and you follow the centiles of the baby. Heart failure, we look at the child, find that he is tachypnic. There is rapid respiration, tachycardia, and an enlarged tender liver. And as we are talking about heart failure, you're going to see that we consider examining the abdomen and looking for a tender liver is part of examining the heart. So the baby is tachypnic. He cannot breathe normally. Okay. When the baby has got pneumonia, يتقال عنده إن هو بينت، يبقى عنده reverse respiration. عنده reversed respiration. During cardiac examination,
we inspect for precordial bulge, and as we said before, the precordium is the area overlying the heart. In VSD, there is a precordial bulge because most probably it presents early in life and it is of long standing if you see the patient later on. There is a hyperactive precordium due to the presence of volume overload, and the pulsations are seen in the parasternal area. By palpation, you can palpate a thrill over the third and fourth left parasternal areas, and it is a systolic thrill, a pan-systolic thrill. When you palpate a thrill, you know that under your hand there is a loud murmur. Murmurs in general are graded from 1 to 6. For a thrill to be present, the murmur has to be grade more than 3. Sometimes large VSDs might not have a thrill.
By auscultation, you hear a pan-systolic harsh murmur over the third and fourth spaces, okay, fourth parasternal spaces. We listen to the pulmonary area. The second heart sound is normal in small defects. It might be loud if there is pulmonary hypertension, but frequently this long harsh murmur might drown the heart sounds. يعني ما بقاش عارفة اسمع الهارت sounds كويس منها وانا في third and fourth spaces. ولكن لو في pulmonary hypertension, I can hear the pulmonary component of the second heart sound accentuated over the pulmonary area. And again, pulmonary hypertension is of crucial importance in shunt lesions. We have to interfere in that patient before developing and establishing pulmonary hypertension. Pulmonary hypertension at first is reversible. If left untreated, it becomes irreversible and you cannot operate on the patient or close it by a device. So intervention has to be done early before the development of pulmonary hypertension. Now listen to the recording of the VSD. That's the murmur of the VSD. In contrast, that's the murmur of a mitral regurg. Mitral regurg is a softer murmur. The mitral regurg murmur, kindly listen to the murmurs with the microphone. The pansystolic murmur of the VSD is a harsh murmur. It is harsher than the mitral regurg. It takes from the first heart sound to the second heart sound, and it goes like that. That's a pansystolic harsh murmur. A softer murmur, which is that of the mitral regurg, is present over the mitral area maximum intensity, and it is softer. It is a pansystolic soft murmur. Of course, there is no hard and fast rule in auscultation and in science in general. So mitral regurg might be a little bit harsher, or the VSD might be a little bit softer. Okay. What is a natural history of the VSD? What will happen to the VSD? VSD, if small, it might close spontaneously, or it might remain asymptomatic. The patient might develop infective endocarditis. Repeated chest infection is common, and congestive heart failure. So you have to treat the congestive heart failure and the chest infection. Pulmonary hypertension might occur, and because this occurs in children with large left to right shunts, due to increased pulmonary flow, and pulmonary hypertension will lead to irreversible damage of the pulmonary capillary vascular bed. This is called pulmonary vascular disease. So what happens in the pulmonary vessels? There is increased flow due to the large shunt. The vessels cannot stand that, and they start to proliferate. and this leads to irreversible damage of the capillaries, the pulmonary capillaries, and they are thickened and they start to close, and this is called the pulmonary vascular disease. Sometimes these patients acquire pulmonary stenosis, and this is very strange. For in an attempt to protect the lungs, the pulmonary valve starts stenosing. The patient is not having pulmonary stenosis to start with at the beginning of when you see him at first, but after a few months you find, or a year, you find that he acquired pulmonary stenosis. Eisenmenger syndrome occurs due to advanced pulmonary vascular disease that we talked about. The patient becomes cyanosed due to intracardiac right to left shunting, commonly occurring after the first 10 years of life. So when we ask you about the complications of VSD and the natural history of VSD, kindly don't start with an Eisenmenger syndrome, because this is not that common. It occurs after 10 years of life, so not common in children, but frequently the baby might be developing repeated chest infection, congestive heart failure, pulmonary hypertension, infective endocarditis. The chest X-ray shows increase in the cardiothoracic ratio, prominent pulmonary arteries, and increased bronchovascular markings, and these are the same findings that we said in atrial septal defect. The ECG shows that there is left ventricular hypertrophy to start with, and when the patient is not managed, he might develop later on right ventricular hypertrophy and maybe pulmonary hypertension. This is a tracing from a 4-year-old boy with moderate ventricular septal defect, and you look at here, there is when you look at V5 and V4 and V5 and V6, these are the leads that we look for the left ventricular hypertrophy in. You find that it is written half here down. This is called half standardization. As I told you first when we mentioned the ECG tracing, that to start with, أنا لما بعمل ECG بطلع بالريشة أعمل حاجة اسمها standardization، أطلع مربعتين وأنزل. ده الطبيعي. لما أكتب هاف كده معناته إن أنا لو كنت عاملة standardization 2 مربعات كبيرة كان الريشة هتطلع بره من كتر لما الليفت فنتريكل كبير، فأنا بعملها هاف standardization. لما أجي أحسب الفنتريكل ده كام لارج سكوير هنا، أقوم أقول لأ ده هنا هو في V4 مثلا عندي 1 2 3 4 و 4.8 مثلا، واضربها في 2 لأن actually this is called half standardization. This is an echo. هنا هو في الايكو ببص هنا هو there is a muscular defect وفي blood بيبقى معدي from the left ventricle to the right ventricle. This is an echo. This is here are 2 chambers. I can see only the 2 chambers, the right ventricle, the left ventricle. هنا ده اسمه left axis parasternal view. ببص على القلب من الجنب. تخيلوا كده اهوت انا ببص على الليفت ventricle مديني الاورطه والليفت اتريوم وراه، وادي دم معدي، ده الدوبلر. الدم اللي انا بشوفه مديني احمر واصفر ده وهو معدي ده اسمه دوبلر. بشوف الدم وهو معدي في الانترفنتريكولار سبتم. الايكو والدوبلر دول اختراعات جميله لان احنا بنشوف القلب من بره من الchest wall and we can see the facts and look at the blood moving from the left ventricle to the right ventricle through a perimembranous defect. This is another echo showing a VSD, a muscular VSD. How am I going to treat the ventricular septal defect? Follow up in small defects. Give medical therapy if the patient is in heart failure. So give diuretics, furosemide or thiazide diuretics and spironolactone. Angiotensin converting enzyme inhibitor. This is going to be mentioned in the heart failure presentation. Prophylaxis against infective endocarditis. You have to manage graft failure and chest infection. Again, managing that is part of managing the ventricular septal defect. Sometimes we have to have good management of graft so that the patient can enter surgery. Closure is indicated by device or early surgery if there are severe symptoms, uncontrolled heart failure and failure to thrive. Moreover, pulmonary hypertension with possible progression to pulmonary vascular disease are indication for early intervention, whether with a device or by surgery. So again, I'm going to repeat: pulmonary hypertension, severe uncontrolled symptoms, growth failure, and heart failure are indications for surgical intervention or device closure in ventricular septal defect. Kindly be prepared with your questions for the next face-to-face session, and this is for further readings, and good luck.